welcome to the Preemie Chats. Preemie Chats is a weekly educational sessions for healthcare professionals and parents to talk about what matters to you, to explore new ideas, and to learn together. I'm Fabiana Bacchini. I'm a Preemie parent and Executive Director of the Canadian Premature Babies Foundation, as known as CPBF, and I'm happy to be your host today. CPBF is a parent-led organization that helps families in and after the NICU through education, support, and advocacy. If you have a heart for preemies, whether you are a family or a healthcare professional, please check our website at canadianpreemies.org. There you'll find resources, the latest projects, and most importantly, a community of people who wants to see our little babies thrive. And if you're watching this live today, please bring your voice to this table. Leave comments and questions in the chat box, and we'll address them during our program. It is through rich conversations like this that we can advance practice and learn together. So please participate and let us know where you're watching us from. So now on today's topic, we're going to talk about cerebral palsy. This talk will focus on providing an overview of cerebral palsy, as known as CP, within the context of children born preterm. CP will be defined and important risk factors, including prematurity, will be highlighted. There is a big international effort on early detection of CP through neonatal follow-up programs. Early detection drives early intervention, and an overview of evidence-based early intervention will also be provided. And I have here joining us live from Toronto, Dr. Darcy Fehlings, who is a developmental pediatrician and professor in the Department of Paediatrics at the University of Toronto. She's a senior clinician scientist at the Bloorview Research Institute at the Holland Bloorview Kids Rehabilitation Hospital. Her clinical and research work focuses on the innovation and evaluation of interventions for children with cerebral palsy, including hypertonia interventions, early detection, constraint therapy, dystonia, and pain management. She's the lead investigator of an Ontario Brain Institute integrated neuroscience network focused on children with cerebral palsy, which includes a focus on the genomics of cerebral palsy. She has held positions at the inaugural head of the UFT Division of Developmental Paediatrics and president of the American Academy of Cerebral Palsy and Developmental Medicine. Dr. Fehlings, thank you so much for joining us here today. I'm so excited to have you here with us. Talk about cerebral palsy, as you know, is a very close cause to my heart, and I'm looking forward to learning more from you.
Well, thank you very much. I'm really excited to be here. I'm really looking forward to the session today. And as Fabiana was saying, please post any questions or comments you have. And hopefully we'll have some fun over the next bit of time together. So I'm a developmental pediatrician, and cerebral palsy is a significant area of focus for me. So what I want to do today is I just want to go over a little bit of information on how we make a diagnosis of cerebral palsy. And I'm really going to focus on a big movement afoot internationally to identify children as early as possible with cerebral palsy. I'll give you a bit of an overview of the causes of cerebral palsy. It's a little bit of a complex story, so I'll try to give you some of that complexity. And then I thought I would go over a bit of information on how we know motor development occurs in children with cerebral palsy, and then talk about early intervention. So what are the key features of a diagnosis of cerebral palsy? So first of all, it's a group of disorders, and it's impacting on how the individual, child, can control their movements. It's caused by what we call as non-progressive disturbance that has occurred in the developing brain. And there's not an age range for this, but it can happen prenatally, it can happen around the time of delivery, or it can happen postnatally. Most children, the disturbance happens before they're 2 years of age. And in addition to the motor issues, there can be other impacts on the child's functioning. So their sensation might be impacted, their learning may be impacted, their ability to communicate. They might have some health comorbidities like seizures. But what is very common in cerebral palsy is there's just really a wide range of how each child is going to present and the developmental impacts. So it's really important to look at each child with cerebral palsy and really look at the child and the family from a strengths-based perspective. So that was a long list of, how we define CP, but here's the key feature. So it's primarily a group of motor disorders where each child with cerebral palsy will have some difficulty telling parts of their body how to move. The injury happens early, mostly in the prenatal and perinatal period, and the brain injury is non-progressive. So if I put on my physician hat, how do I look at making a diagnosis for children with cerebral palsy? I take a history and I look at the risk factors. I want to hear about how the child is developing, and I want to get a little bit of information on the family history. Is there any history of neurodevelopmental issues or other children with cerebral palsy in the family? I'll then do a physical examination. I'm really concentrating on the neural exam and the musculoskeletal exam. And then I'll often talk about doing some investigations with the family. So one would be looking at any brain imaging that's happened to date, or we can talk with the family about whether we should do a brain image. And for some children, we're also looking at other testing such as genomics. I then try to put this all together and with the family, look to see if we're making a diagnosis of cerebral palsy or not. So one of the really exciting things about an area of focus in cerebral palsy right now is making the diagnosis as early as possible. So if you look here at this last bullet, we are trying to make a diagnosis in children under 12 months of age. And this is very different than what I was taught as a pediatric resident, where we were encouraged to wait until the child was at least 2 years of age before we made a diagnosis. But we're trying to make them as early as possible. And there's a lot of work going on at an international level to accomplish this. I was really pleased to be involved in this very important clinical practice guideline called Early Accurate Diagnosis and Early Intervention in Cerebral Palsy. And it was published in JAMA Pediatrics in 2017, and it's open access. So for any of you who are interested, you can go and access this particular document. It's long, it's clearly written, and it's outlined some things that we can do to make a diagnosis early. So this is particularly relevant in children who are born preterm or prematurely, because we know that prematurity increases the risk of developing cerebral palsy. And so a lot of the area of focus of this particular clinical practice guideline is looking at what we can do in the neonatal period and the neonatal follow-up to be able to encourage an early diagnosis of cerebral palsy. And we've identified these 3 key tools. We won't have time to go into them with a lot of detail today, but one of them is a general movements assessment. And it looks for the presence of fidgety movements. And typically developing children have fidgety movements, and we can detect those up to 12 to 16 weeks of age. And it's very reassuring when we see them. We could also take a picture of the brain with a brain MRI that doesn't involve any radiation. And for neonatal units that have an MRI compatible incubator, we can do these MRIs when the child is asleep, so they also don't need to have sedation. And getting information on how the brain is looking and seeing if there's an area of injury can give us clues as to whether this child might be at risk to develop cerebral palsy. And then I've got 4 little letters here, and it stands for the Hammersmith Infant Neurologic Examination. I'm a huge fan of this exam. It just teaches people how to do a structured neurologic examination for a child anywhere from 3 months of age to 2 years of score. And we get clues from the score on the hind in terms of whether the child might be have a high probability of developing cerebral palsy. So this is just a little picture of some of the items on the Hammersmith. You see these cute little figures, but they contain a lot of information. And then we just would look at the child, see where they're falling, and then each of these columns gets a score. So it's a way of standardizing our neurologic examination, both within the neonatal follow-up clinics. So if you're working with therapists, occupational therapists, nurse practitioners, we would all administer it the same way. But also we can talk to other neonatal units with information on these scores. So why is early identification important? So I have some statistics here. In Canada, our average age of diagnosis for cerebral palsy is 19 months of age. And in the clinical practice guideline, we said we really want to make this diagnosis before 12 months of age. So there's opportunities in Canada to do a lot of work on early intervention, early detection, and then early intervention for children with cerebral palsy. And in some countries, particularly low to middle income countries, that age of diagnosis can be even later. So we are doing some outreach work to Ethiopia right now, and their average age of diagnosis of cerebral palsy is 5 years of age. And we've worked with the team there to introduce the Hammersmith. And in those clinics, they were able to get the age down to 10 months, which is really spectacular. So you might be thinking, well, why is this important? It's important because if we can detect a high probability of cerebral palsy or make a diagnosis of cerebral palsy early, then we can get that child connected to therapy early. And we know from neuroscience that the earlier we can start to guide some therapy, the more the child will respond to the therapy. And it's particularly important for our most common type of cerebral palsy, which is hemiplegic cerebral palsy. That's where the child is having difficulty using one side of their body. And if we can get the children connected to early intensive hand therapy before 7 months of age, their hand function will improve compared to if we connected the child at 12 months of age. We wouldn't see quite as much improvement. So let's move on to talk briefly about the causes. And so one of the really exciting things that I wanted to share today is that we're actually seeing a drop in the prevalence of cerebral palsy. So if we were to look at numbers from about 5 years ago, we were sitting at 3 to 5. And now we're sitting at just under 2. And one of the exciting things that I wanted to share is where we are seeing a drop in the prevalence of CP is in the preterm population. So that's really exciting to share today. And it really relates to enhanced neonatal care and some changes in the way ventilation and respiratory support are provided. And what we're seeing is that with these gentler ways of providing ventilation, that the children's neurologic status is relatively protected and we're seeing a drop in prevalence in the premature population. So that's really exciting news to share today. Now, this is a complex slide, and you don't need to read all the details. Basically, what the slide is saying is that there's many things that can interact together to put a child at having an increased probability of developing cerebral palsy. So often it's not one single cause, it's many that are interacting together. And that's what makes understanding of the etiology of cerebral palsy a little bit complicated. But I wanted to share with you what are some of the common factors that can increase the probability for cerebral palsy. And you'll see that I put prematurity up there. Also, if the baby is too big or too small, if there's a history of infection or inflammation in the baby or in the placenta as the mom is pregnant. There also, if the child has a stroke in the prenatal period or perinatal period. And also if you're more than one baby, so multiple gestations like twins or triplets or quadruplets, that would put the child at a slightly higher risk of developing cerebral palsy. So just related to prematurity, seeing as this is a Preemie chat, if you're born prematurely, you do have a heightened risk of CP by about 100. Now, we need to recalculate that number because I just shared that good news that we're seeing that rates are going down with prematurity. So I'm expecting that number will start to drop. But when we look at, what are the risk factors for prematurity, we see there's many different things that can lead to a baby being born preemie or preterm. The other thing I wanted to just explain, so if there are any parents of children with cerebral palsy, one of the things that you will notice in your child is that the child often has increased stiffness in their muscles. And this is just a little physiology as to why that happens. So here's the brain, here's the information going down the spinal cord, and then the information going out to the muscles. And the brain acts as a regulator for the remaining part of the system. It sort of acts like a dampener in terms of tone. It keeps tone regulated. And if there's an injury to the brain, then it doesn't do as good a job at regulating the tone. And then we see increased tone going out to the muscles. So that's why increased tone is such a common feature of children with cerebral palsy. Now, the other thing that is a little bit complicated with CP, and again, please don't worry about the details on the slide, but I just wanted to make the point that there's lots of different types of cerebral palsy. And one of the things we look for are different tone types. So we have spastic, which means that the child has pretty consistently increased tone. And then we have something called dyskinetic, where the child's tone can really vary a lot. And then the other thing that we do is we look at a description of how many arms and legs are involved. So if both sides of the body are involved, we say bilateral. If it's just one side of the body, we say unilateral. So I mentioned earlier hemiplegic cerebral palsy, and it's our most common type of CP, sitting at just less than 40%. And then the other thing I wanted to point out to this audience today is that if you're born prematurely, children can have diplegic cerebral palsy as a common type associated with being born preterm. But we're also seeing that hemiplegic CP can be associated with being born preterm. And I'm going to explain a little bit why that is. So This is a diagram courtesy of one of my good colleagues, Dr. Adam Curtin, who is a pediatric neurologist out in Calgary, Alberta. And here, I don't know whether you remember being in the neonatal period with your Preemie, but you probably were around some children who were having head ultrasounds to look to see if there were any tiny little brain bleeds in the brain. And children, when they're born prematurely, the blood vessels in the brain are a little bit fragile, and they can have small bleeds. And in this particular diagram, we can see in the bottom left-hand side of the slide, the child's had a small area of bleeding. But what that's done is it's led to a backup of flow coming from the bigger area of the brain. And then that's led to difficulty controlling the other side of the arm and the leg. And so this would be a cause for hemiplegic cerebral palsy that we sometimes see in babies who are born preterm. And then the next slide is a picture of a brain ultrasound. And if you look at where the little white arrows are pointing, they're pointing to a little black area. And that is an area that sits beside the large fluid-filled ventricles in the brain. And it's just showing us that that area of the brain has an area of injury. And when we're born preterm, that area of the brain has high metabolic needs and is just at risk to have an injury to it, either from infection, inflammation, low blood pressure. And we can pick up these changes on ultrasound. And as I mentioned before, the good news that we're seeing less children born prematurely developing cerebral palsy, it corresponds to us seeing less children with head ultrasounds and MRIs that show this area of injury beside the ventricles. So again, really exciting progress happening. This is an MRI picture of the same phenomena. So you can see that we have more details. And the white area in the brain, that the white arrows are showing that lighter gray area, and that's the white matter injury. And in that area of the brain, the legs are traveling through that area of the brain. And so the message going to the legs of children that have this injury is going through less clearly. And so that's why these children can develop a type of cerebral palsy called bilateral spastic diplegia. So we can link the MRI picture or the ultrasound picture with the subtype of cerebral palsy that we may see with the child. So that's why getting a picture of the brain can be helpful. I wanted to tell you a little bit about an important classification system that has been developed for children with cerebral palsy. And it has been developed by good colleagues down the road from us at McMaster University in Hamilton, Ontario. And it's called the Gross Motor Functional Classification System. So we used to say words like mild, moderate, severe. But when we were talking to other people, their mild might be very different from my mild, or their severe might be very different from my severe. So what this classification system has done is it's just given us a common language to be able to refer to. So we would say level 1, so children with cerebral palsy are able to move around in all settings. Level 2, they could go up the stairs, but they need to hang on to a railing. Level 3, they can move around by a walker or wheelchair. Level 4 requires wheelchair or adult assistance. And level 5, that they're fully dependent for mobility. So that if we said level 1 cerebral palsy, then you would know that the child is able to really walk around and move around their environment well. This information was then intersected with information on the child's gross motor function over time. So if we see the x-axis, the horizontal axis here, we can see information on how the child's motor development changes with age. And one of the really interesting things is you see these vertical dotted lines. That tells us when 90% of the motor development will happen. And you'll see it's very, very early. So this information is really helpful for parents to understand, but also for healthcare providers to understand, so that we have information on what we might expect the child's motor development to do over time. Now, I'm going to end my initial comments with just talking a little bit about early intervention. Again, a really important clinical practice guideline that has been published in JAMA Pediatrics, one of our top pediatric journals, and it's also open access. Do you see how it says free article? So you can search for this online as well. And very pleased to be a co-author on this clinical practice guideline that was led by many people, but Catherine Morgan, Linda Feathers, and Iona Novak in particular. Now, this diagram also is very complicated, but what you can see in this article is that the group has come out with recommendations in the green, that light green that says, look, this works. And you see that pinkish red color, we're saying, hey, wait, this doesn't work. And that's really helpful when you have cerebral palsy or you're a parent of a child with cerebral palsy, because there's a lot of different therapy options out there to have some guidance around the quality of the evidence informing these interventions. At the very top, there are some really important general principles. So one of them is that you want to work with the family, the child and the parent, to set goals. And the other one that you want to do is you want to coach the parent and develop parent expertise, because that's how the treatment can generalize into the child's day-to-day environment. So the initial slide just gives information on motor, cognition, etc. And then this gives information on sleep and musculoskeletal health. So it's a wide-ranging clinical practice guideline. So just in terms of the summary for that particular intervention clinical practice guideline, we want to push early detection of cerebral palsy. And in children who have risk factors, like children who are born preemie, we can make a high probability of CP diagnosis under 6 months of age using those key tools. We know that neuroscience tells us that the earlier we can start intervention, the more impact it will have. And so we really need to work together, and we are, to build access to evidence-informed early intervention. So one of the things I'm really pleased to support and be actively driving here in Canada is baby constraint-induced movement therapy. And I'm smiling a little bit because the CEO of Holland Bloorview said, Darcy, I think you need to have a rebranding of this particular name. Baby constraint doesn't sound so positive. But what it's suggesting is that for children with hemiplegic cerebral palsy that are sending a clear message to one hand, but not a clear message to their other hand, that if we gently block the message going to their good hand and encourage the child to play with toys and grab objects with their hemiplegic hand, we can make a big difference in the child's ability to use their hand. And this is just, it's a very gentle, so despite the bad name, it's a very gentle play program for children where we're encouraging play with their hemiplegic hand. And finally, I wanted to finish with the 6 F words for childhood disability. I'm a physician, and I think physicians have sometimes erroneously focused on medical problems and medical impairments. But when you're working with children, it's really important to have a strengths-based approach to how you focus your recommendations. And again, this work has come out of McMaster and Canchild. And I think it's just really powerful messages that we should focus on the 6 F words for childhood disability. So 1, promoting function. 2, promoting the child within the family, within the community. 3, supporting fitness. I'm smiling here because I've been working with an engineer, Professor Nick Graham, to develop a Peloton-like bike called the Liberty Exergame that children can sit on. And the more they pedal, the more power they have to play the computer game. And we can connect it with other children playing the game in other parts of the world. So we're really excited about that ability to promote fitness with our Exergame. Friends, critically important. Children, whether they have a disability or not, they all want friends. It's a key component of childhood. And promoting future, and I'm blanking on the last, the 5th one there. I always forget one of the 5th ones, but it's covered by my slide. So with that, I'm going to say thank you and open it up for questions. Oh, you're muted, Fabiana.
Sorry, you see, after 300 sessions, I still forget to unmute myself. But thank you so much for such a great presentation, for really shining a light for parents who might still be in the ICU or coming home and not knowing where to go and what to expect. This was such a great presentation. I have a few questions for you because we're all now talking about this early diagnosis, early identification of cerebral palsy. And one question that we've been talking about is to have MRI done still in the ICU, because you have the brain ultrasound, but not necessarily is going to identify whether the child's going to have an issue or not later on. And there is this movement asking for MRI in the ICU. First of all, what are your thoughts on that? And also, can we talk to parents at MRI and what does it going to look like if the MRI does show some signs of brain injury?
Yeah, that's a really layered question, Fabiana. It's an important question. So let's start with the head ultrasounds, and then I'll go to the MRI. So the head ultrasound is a fabulous tool. And it is something that can be integrated into a large number of neonatal follow-up units. So it's very accessible. And as we work with the radiologists, the head ultrasounds can actually give us a lot of really practical, good information, particularly I showed you the pattern that we look for children who are born Preemie. It's something that can be done in the unit. It's very portable. So I have only positive things to say about the head ultrasound. But when we look at our evidence for the clinical practice guideline, we did a deep dive. And what we found was our gold standard best tool was a picture with an MRI. And there's a shifting landscape of MRI capabilities. But the more recently developed MRIs can really give us a lot of detail. And in particular, give us detail. If we think about the brain, this is an oversimplification, but if we think about the brain being made up of gray matter, which is predominantly the nerve cells, and then white matter, which is predominantly the train track connections between the nerve cells and the body. An MRI is certainly picks up gray matter injury, but it's also very sensitive at picking up white matter injury, much more so than, say, a CAT scan, which involves radiation. So MRIs are much better than CAT scans. And MRIs and PET ultrasounds, they can work together. So for an MRI to be done, we need to have the baby still. And so, and of course, they're often in the neonatal unit. There can be a little bit of instability in terms of their health. And so one of the advancements has been the ability of having an MRI incubator. A baby can stay in the incubator. They can time the MRI when the baby's asleep. And so we don't need to use sedation. If we wait too long, so let's say we're trying to do an MRI at 2 years of age, for example, there's no way you can do an MRI. I shouldn't say no way. We're now trying, if the baby's asleep, we can, try to get the baby, but it's much more challenging. So what is a gold standard is being able to access an MRI in an MRI compatible incubator about the time that the baby is at term when they're in the neonatal intensive care unit, if there is a significant neurologic concern that's been raised. So we would never want to do an MRI on every baby in the neonatal unit. But let's say we have a baby who was perhaps born at term and had a difficult delivery and had sustained a neurologic injury and is receiving cooling, then we would like to have an MRI picture, and we would look to see if there is particular gray matter injury for that particular scenario. Let's say we have a baby who's preemie, who has had a challenging time in the neonatal intensive care unit. The head ultrasound perhaps has shown some areas of concern. Then that baby also could potentially benefit from an MRI where we get much more detail. So the MRI units, it's an act of evolution. People are aware that if we use a combination of that general movements assessment, that looking for fidgety movements or not, and pair it with the Hammersmith and the MRI, we have more information, and we can do a better job of predicting whether a child may have cerebral palsy or not.
Wow, great answer. And I have one more question to add to that. Having the identification that the child has a more probability of having CP or not, do we know how the CP is going to show up in that child's life? Or we have to wait until the baby, maybe is a toddler, to see how is the motor function working, or if it affected the speech or other functions?
Yeah, so for sure we get information from the pattern that we're seeing actually in any of those three tests. But for the MRI, for example, if we're showing, that one picture where I had that baby that had the small bleed and then had the difficulty with sending a clear message to the other side of the body, if we see that pattern on the MRI, we might predict that that child would develop hemiplegic cerebral palsy. One of the really interesting things about the Hammersmith is that it comes with a maximum score of 78. And if the score is persistently lower than 40, then we know that those children may have a higher probability of developing GMFCS functioning 3, 4, and 5, so that we know that there's a relationship between the Heinz score and the motor functioning severity.
Okay, so this is a comment and a question from Samoa, which is, we always see this in our Preemie group because we always talk about milestones, corrected age versus actual age. So I just want to bring this up because I think especially now the babies are born at 22, 23 weekers, and the parents have even more questions. So she said, my preemie was born 23 weeks and 4 days, and she had grade 2 bleeding in the head. She's 6 months corrected, 3 months, and 2 weeks adjusted. She's holding on to a rattle. Is she doing great? Or I think the comment got interrupted because too many characters on StreamYard. But this is such a common concern of parents in those early months after discharge from the NICU. And that's why we always encourage parents to do go to neonatal follow-up. But I will let you talk about these milestones, what to expect, corrected age versus actual age.
Yeah, it's a fabulous question, and I'm so pleased to hear she's holding onto a rattle and she's at home, and that's so important. That's fabulous. So one of the really positive things that's happened out of this energy to do early detection is that many of the neonatal follow-up units are switching their first neonatal follow-up checkup to 3 months of age. And that's really important because we can do that general movements assessment to look to see if there's this fidgety movements or not. If there's fidgety movements, we're feeling reassured. But also the Hammersmith is just so helpful because we can start to do the Hammersmith at 3 months of age. And you're absolutely right. We should do corrected age, which we do. And then we can give you information on where your child's Hammersmith score is sitting relative to other babies who are born extremely early. So we have scores. Most of the score information is coming out of a fabulous neonatal follow-up program from Italy. And so we have a range of scores for typically developing preterm infants when they're 3 months of age. So we can give you some information there before some of the motor milestones. It's often a little bit early to look for motor milestones at 3 months.
Okay, so I have another question here from Marisa. Do you see a lot of preemies with CP with normal brain imaging? My 25-weeker has hypotonic and dystonic CP, but all normal imaging. Doctors think it's genetic, but all testing has been normal.
Yeah, so again, a fabulous question. So if we were to look at 100 children with cerebral palsy, interestingly enough, about 5% of the children would have normal brain imaging. And despite our fabulous detailed MRIs that can give us lots of detailed information, it's still at a very high level in terms of looking at how the nerves and axons are functioning in the child's brain. So we do see it in about 5 out of 100 children with cerebral palsy. And it's good that your physicians are perhaps saying, well, should we do some genetic testing? Because we know that it is a marker that MRI being normal, that it means that we maybe should look to see if we can get information from our genetic makeup in terms of how the nerves and axons are functioning. It sounds like they've done that. The genetic workup has come back unremarkable. So that sounds very good. Ultimately, at the end of the day, we really look at the child and how the child's doing in terms of what our recommendations are for therapy. So even though the brain MRI is not showing any changes, we get more information from the child, and we can still make really good recommendations in terms of what the interventions could be to help.
Absolutely. I just want to bring Brenda's comment, one of my favorite clinicians. Dr. Fehlings, you have a lot of parents that love you and love the work that you do, and we are so grateful for that, including myself. One more question that I have regards the early detection, because now we are talking about very early detection. And we know, even for me, 11 years ago, we had to wait until my son was 2 to be picked up at a rehab center to start therapy there. But because I was proactive, I had to start earlier because I knew he was falling behind. So now when we talk about the system, if this family comes out of neonatal follow-up clinic with, this early detection of CP, is our system ready and prepared to pick up those child for early intervention, early therapies to optimize, their potential and whatever that is going to look like?
It's a fabulous question, and I would say that there's a lot of work to be done to massage the system so that we're better prepared. And you mentioned some of the research projects that I've been involved in, but the one that I'm putting the most energy into right now is really this early detection and early intervention, because I think it's really important. And there's a lot of change that needs to happen. So we've for right or wrong reasons, we've decided to try to focus on baby constraint. And part of the reason behind that was that it's our most common type of cerebral palsy. And we had really good evidence that baby constraint programs really work well. And so we've been really working to drive national access to baby constraint. And I'd say we've seen some success over the last 2 years. There's opportunities to drive all sorts of other interventions. I work with Professor Annette Niedemer, who's in charge of the Child Right Network, and we've developed an online edit CP toolkit. And the part of the toolkit covers a range of interventions, and we hope that that will be helpful as well. Multi-pronged strategies to support our therapists to provide the range of options for early intervention, and then a lot of work on access so families can easily find services in their area. So
wow, that is so important. Yeah, that is so important, especially for families who live in remote areas, northern Canada, northern Ontario, where the services are not, they don't live in big centers. It's not easy to access. So this is very important. So we talk a lot about early detection, early intervention, but for the families who already have diagnosis, what is for us to look into the future? I know you are doing so much beautiful work, so many new research projects coming up, and one that I'm particularly interested is the metformin study. Can you share with our audience, what are you working on? What can you look forward to in the near future?
I definitely am happy to answer that question. I like to have a balanced portfolio, and what that means is that I try to put energy into things that I think are going to be important and impactful. And so my first response is to say, I really think the success is an important message, and focusing on things that are strengths-based, fun, friends, family. One of the really exciting programs that I'm working on right now with a PhD student, Daniela Testani, is we know that children with cerebral palsy can have restricted participation even when they're preschoolers. And so she's developing intervention to support parents in terms of encouraging that child to get out into the community and participate and make some friends. We know friends is really important. The Exergame bike to promote fitness. We know that we're often sitting a long time in front of our computers, but if we think we're a child with a physical disability, we're going to spend more time sitting, and we really need to worry about fitness and work on fitness. So having fun ways of playing and being fit is really important. But let me get to your question around metformin, Fabiana. So I am a big believer in something called a translational neuroscience network. So we work with stakeholders, we work with basic neuroscience investigators and clinicians, and that triangle is very powerful. And one of the things that we heard coming out from our translational neuroscientists was there's a medication called metformin that can help to induce an endogenous, that means inside of ourselves, stem cell response. And so we do have a small trial, it's a feasibility study to look at the safety and to explore if there's a signal looking at metformin in children with cerebral palsy. And so we're actively recruiting for that study now. So yeah. We don't have the results yet.
Yes, no, but I think, I mean, there's so many amazing projects you're involved in. I'm just sharing the Holland Bloorview website here, and also the Can Child. I know the F words are also there in many, many languages because you have an international audience and it's being translated around the world. And can people find other projects on this website, Dr. Fehlings? Is it the right one that we can share?
Yeah, that's a great one. The CPNet and the Can Child site, CPNet, we have our research projects written there. If you go onto the Holland Bloorview site and you're particularly interested around reading, some of the research projects I'm involved in, you can go into my scientist profile and you can get a description there.
That is wonderful. Dr. Fehlings, thank you so much for joining us here today. I am so grateful to have you here to share your expertise and experience with our families and our audience today. And we are so looking forward to the future for our children and for new families to come. I think today you gave us great news that the rates of CP are dropping in the preterm population. I think that is something incredible that Canada is being really working hard towards that. And it's such an incredible news for our community today. So I'm very grateful that you join us here and share those news with us as well today. Thank you.
Thank you for the opportunity.
And to all of you watching us live today, thank you for joining this episode of the Preemie Chats, and a special thanks to our sponsor, AstraZeneca, who makes education sessions like this one possible. And just a reminder that if you miss part of today's sessions, head over to canadianpreemies.org. I'm going to share the website right here. Give me 1 second. canadianpreemies.org, and to see this episode and all past editions of our Preemie Chats. There you'll also find many resources and support options available, and you'll be reminded that CPBF is a charitable organization and depends on support to continue its important work. Consider how you can support CPBF and its mission to empower families of premature babies every step of their journey. Together, we can create a brighter future for all preemies and their families. And we'll see you again next Friday, 1 p.m. Eastern Time. Stay well.